So, if you joined us to learn about what hurts pain, part 2, addressing and treating pain in Rett syndrome with our team of Rett expert researchers and physicians, you have come to the right place. This is Paige Nuez. I'm Director of Family Empowerment at RettSyndrome.org, and on behalf of our Board of Directors and everyone at RettSyndrome.org, we want to thank you for being with us today and for your support and engagement. Continuous awareness and empowerment is critical to your success and our shared success on this journey with our loved ones with Rett syndrome. And I say this both as a parent of a beautiful teenager with Rett syndrome and as your advocate at RettSyndrome.org. So I want you to know that we are continuously pushing for new and innovative findings and committed to helping you on your journey today. Thank you to all families, caregivers, clinicians, researchers, and industry representatives for being with us today, as well as all of our speakers. We believe that information on our rare disorder should be free to all who avail themselves of it. And we especially want to thank Novartis and Taysha Pharmaceuticals for their generous support for our educational programming. Next, we're gearing up for our Ascend 2022 Rett Syndrome National Summit in Nashville. This event was designed to unite us as a community, and we'll be bringing together parents, caregivers, families, clinicians, researchers, and Rett organizations. Because we know that together we can overcome the challenges of Rett syndrome and reach the summit of hope and healing, and ultimately a world without Rett syndrome. So please save the date, April 27th through 30th, 2022. It will be so great to once again be together in person. I have a small promotion that I want to share with you. Billy Footwear is one of our favorites because of the ease of the use of their shoes for our children. They have partnered with us. If you want to scan that QR code, you can visit and receive 10% off of your entire order, and RettSyndrome.org will also receive a portion of sales. So thank you, Billy Footwear. Okay, and just have to give a shout out. This week is National Volunteer Appreciation Week, and we want to thank all of our countless volunteers who give time, talent, treasure to help us create a world without Rett syndrome. We're grateful for each and every one of you. I see many of you here with us today. Just a few groups who serve our organization are our board of directors, scientific and medical advisory boards, our Family Advisory Council, Family Empowerment Representatives, our fundraising event chairs, and our panelists today are volunteering their time for you. We have industry advisors, state proclamation advocates, and so many more who enable us to accomplish our very broad mission. So congratulations and thank you for all of the success you've had. Next, I wanted to mention the communication guidelines. Most of you are aware that the communication guidelines were a 6-year research project funded by RettSyndrome.org, and these guidelines are published and available for you to download. In particular, we're going to talk about how you can understand pain and how our children can communicate what hurts and where it hurts. And by utilizing the communication guidelines, we hope that you'll be able to bridge that gap in this area as well as many other areas, especially in this time when our kids some are still online or hybrid. The guidelines will help everybody with Rett syndrome reach their communication potential. And the guidelines have been translated into Spanish. So again, you can just scan that QR code and figure out how you can access the guidelines and put them into practice in your life. And last, a reminder that our Rett Research Ready tool will help you find information on how to be research ready and find clinical trials, observational and virtual studies, and research surveys that your family can participate in. This is the place where research cannot advance without us engaging and participating. And so we've tried to make this tool very easy for you to connect with studies that are available for your participation. Scan the QR code and it will take you to a place where you can learn more, especially about these 3 studies that are currently seeking participants. Okay, so I'd like to first introduce our first speaker, Dr. Frank Simons, who presented, hi Frank. Dr. Simons was with us in August and presented Pain Part 1. He's with the University of Minnesota, And he really, I'm looking for your quote, your favorite quote that I love so much, which is, understanding the cause of things must be preceded by an understanding of the things caused, which actually is a quote from Hewlings Jackson, which I think is central to your work. And Dr. Simons, we are wondering if you could give us a summary of what we talked about in August to get us oriented and grounded for the rest of our presentation today.
Happy to, Paige. Thank you so much, and welcome back for those of you who were with us in August. And I've done some growing, not height-wise. My face got longer. I haven't. It's my little COVID beard project. And for those of you who are just joining us for the first time, welcome as well. And as Paige said, this is part 2, and I was part of part 1. And I think the idea here is it's an Olympic year, so we'll do the handoff. And I'm going to just make a few comments where I left off to remind you of some of the points I was trying to make. And I've got Dr. Barney, Chantel Barney is helping me here work the slides. So, and remember, I was contextualizing, I'm the academic egghead of the bunch. And so part 2 is really an effort to get to useful information. And so we brought in the real doctors and people that use knowledge to make a difference. And I was trying to create a context for some of the issues that we face as a field in research and practice, and some, history and sociology and political statements about individuals living with severe support needs, serious support needs related to developmental disabilities in general, and Rett in particular. So my science summary, just again to remind people, was I think there's been progress again broadly in the behavioral science field as it relates to thinking about pain and this developmental disability. And my term for it is that we've built, and it's not we as a royal we, not our group per se. There's been efforts to build better mousetraps. So by that I mean we're trying to capture and measure pain. And so there's a number, and you'll see in a moment with Dr. Barney's piece on toolboxes. What we didn't have a decade ago were checklists and rating scales that were either modified or built new to help identify behaviors and related markers around pain and pain expression in individuals with who are either nonverbal or are living with a variety of motor and communicative impairment. And so we built better mousetraps. I think there's still an ongoing need. There's progress, but what I called consciousness raising, and there's still a need for. I talked a great deal about bias and beliefs. There's a long-standing history of biased belief about individuals with significant impairments, that whether they're intellectual, communicative, or motor, or any combination thereof, about people being considered either indifferent or insensitive to pain. And so I think a number of groups globally have chipped away at that belief to suggest, in fact, we should be concerned about pain, and we think there are ways to go about measuring it. Some of the problems I think that we still have, if we built better mousetraps, I don't know if we've caught more mice. And by that I mean there are tools. The question is, and it's a different kind of science and research question, are systems taking up those tools and using them? And if they are, what's the evidence for that? And really what matters is pain being better treated. So there's a knowledge transfer, knowledge translation, implementation set of issues, and Dr. Barney is literally at the frontier of that. And I just as I don't know what a cheerleading statement, I can't say enough about what she's doing, and Gillette Children's for supporting the work in terms of a knowledge transfer, knowledge translation initiative that she's a big part of. And then other problems, again, I'm speaking again as the academic scientist of, news from the bench, right? The basic science of which the University of Minnesota has a lot of bench experience, and we talk to those folks routinely, and this may seem trivial, but not all pain is the same. There are very different pain sources. We know that, and you know that. You put a long list of questions together, and underlying that, and I'm sure that Dr. Beisang and Dr. Schwantes will speak to this in part, there are different pain pathways and different molecular mechanisms. Again, and so that's being established in preclinically in mice models too. And the question is, how do we translate that knowledge, new knowledge about pain mechanisms from the bench to the clinic for Rett? And that's something that we're active in, trying to figure that out. And so some of the promises, I think, that we're at, it's not the future, it's in the future, but the future's here. And so many of you know this, we've been active in the Rett research community of thinking about biomarkers. And what we're always trying to push is, what's their validity? Is it useful to look at different kinds of behavioral or biomarkers, things we might collect in saliva or blood or skin? And do they help us understand in more detail underlying mechanisms, but do they also provide clinical utility in terms of predicting perhaps treatment outcomes for pain or analgesia? And then just my little soapbox reminder that a biomarker is not an assessment of an individual feels, functions, or survives. And so there's sometimes confusion out there. And I spent several slides back in August of, the word pain and the word nociception. Those aren't really interchangeable if we're being clear about things. And so if you're in one of our protocols and we're collecting saliva, it's not like we're going to look through the microscope and say there's pain. We're trying to understand what different molecules that may be involved in the signaling, the nociceptive signaling from the arm or the leg to the brain, and how does that work? Is that pain or is that not pain? Those are related but separate issues. So that's a quick science summary of what I think of progress, problems, and promises. So, but there is a long list, and again, the questions you put out in pain part 1 and now pain part 2 attest to this, of largely unattended clinical care. By largely unattended, I mean in the research community, for people like me to get busy and take these up that relate directly to clinical care. There is not a lot of guidance. We saw a page alluded to the communication guidelines, 6 years in the making. I would like to see something like that in health in general, but pain, whether it's acute management, chronic, or post-operative in Rett. So advanced post-operative pain management, decisions about dosing and frequency, sequence, timing, modality, decision-making about the pain management options, pain assessment and cognition communication, again, of how to move the knowledge that we've done in more controlled environments into bedside and clinic routine application. We all know there is a myriad number of non-pharm approaches. How well do these work in girls and boys living with Rett? And then the fact is that your daughters, and for some of you, your sons, are exposed to repeated procedural pain. And we know from other clinical populations, as well as basic research, this can set up issues in its own right. And so how well are we attending to that and making those procedures as pain-free as possible? So there's a long list of issues, and you're living it and you know it, and I'm saying, I'm acknowledging, we recognize this, that research should be brought to bear. And so just finally, our local program of research, to repeat, I would contend that pain is yet not well understood or fully documented in terms of expression and experience in Rett. And so that is one of the things we're really trying to chip away. And so are other groups. There are several other groups internationally that are interested in pain and Rett. We know there are sort of the daily challenge, right? That's where we try to position ourselves between the U of M, the Midwest Rett Syndrome Foundation, and Gillette, is the whole kid, the whole patient, the whole girl, the whole boy, not at the bench or not 30,000 feet from natural history study, but what to do about chronic health problems as lived right now, and how can we best recognize earlier that there may be a problem and it may be pain relevant. And then the ongoing challenge, of layers of the onion kind of thing, of exposing and talking about people's beliefs around pain insensitivity or indifference as it relates to what providers report or caregivers, families, etc. And that complex interaction of how people, what they're bringing to the table about their understanding of pain, their own experiences with pain, their own beliefs about pain, and then the beliefs that they have about their child, your child. And that's the psychosocial aspect of this thing called pain. That isn't the neuroscience, and it's related and relevant. And so we're very much interested and active in trying to think through those things too. So that's a quick summary from part 1. I really appreciate the opportunity to come back in and be a part of this and listen. And I will now hand it off to Dr. Barney.
Okay, thank you, Frank. I will. Can everyone see my screen? Phil? No, I can just see myself. Okay. So I'm going to take it from here.
And Dr. Barney, if you don't mind, I'm just going to let everyone know that the scales that you're talking about are attached as attachments for the presentation, and everyone is welcome to download these and use them. As Dr. Barney is going to explain, you can best use them in your life. If you have any trouble downloading, just type it in the chat and we'll help you. Okay. All right. Thanks, Dr. Barney. Please proceed.
Of course, absolutely. And if you have any questions or want more hands-on support in measuring your child's pain, please email me. I would be more than happy to help give you more support on an individual basis. So my email address is there, or Paige can connect you as well. So I just wanted to speak a little bit about an initiative we did at Gillette, where we had implemented several different pain assessments that were part of a toolbox that I think Frank more thoroughly talked about last time. We trialed them in several different clinics that served patients with complex developmental disabilities, including some girls with Rett. And then at the end of a year of trialing all these different pain assessments in different clinics, we had providers come together to work on a simple, effective, and efficient, well-validated scale that would be more readily adopted throughout the hospital, and that would give consistent pain assessments across clinics. And so they came up with this assessment that's really a compilation of a couple of the best pieces of different assessments that they had tried. And we find it to be pretty useful, and we hope that it's also effective. We believe it will be effective in the homes for sure, and that it's efficient enough that you can find it useful on a daily basis. So it gives first some information on the pain intensity, which would be rated from a 0 to 10 by you and your best judgment. And then it goes through some items on pain interference and how that impacts activities and daily life. And then there's an assessment on the second page specifically on nonverbal pain-related behaviors that can give you another intensity rating, but is a little bit more based on your observations than your gut instinct of that 0 to 10 scale. And so this is an overview. You'll see that in your download of the 2 pages. And so now we'll dig in a little bit to page 1. So this is unfortunately not adapted specifically to parents. This made me realize we need to do that so we can get this in more parents' hands. So just ignore the top. That's not really applicable when you're the parent. I'm not using it for clinical patient use. So we'll zoom in on the first section is about pain intensity. Now, if you've gone to clinic and been asked about your pain, you probably asked, what is your pain right now, or what is your child's pain right now, from 0 to 10. And that gives some information, but really your pain right now isn't really reflective of what you've been experiencing over the past week or even the past month, or what problems you might have with pain. So we think it gives more information to ask about the worst, least to know whether the pain remits at times, and your average pain. And then the second section talks about pain interference from does not interfere to completely interferes with these different 12 items, including sleep, mood, mobility. So this not only tells us a little bit more objectively of something that you can observe of how pain might interfere with sleep, for example, but it also gives you and your providers some input on different areas to tackle. Like if pain does really interfere with mobility or sleep, there's kind of an obvious referral potentially to like a sleep health clinic. Or maybe to get wheelchairs adjusted or AFOs adjusted, things like that. So it can help with targeting a few intervention options too. And then moving on quickly to the second page, this is the pediatric pain profile. And this is the part that gets you looking at your child's behaviors and noticing what you might have seen. I want to point out this one says the last week, just for consistency that we chose that time frame. Across Gillette. You can certainly adjust this. The scale normally has a blank there actually, and you could put the last 24 hours, you could put the last 15 minutes, whatever really works for you and your needs. And then you're going to score each item from not at all to a great deal, and then you put them in the score column. And for example, if something you can't observe, so you said you want to look at pain in the last 15 minutes, minutes when your child wasn't eating during that time, you would say unable to assess and assign that a 0 to gather your total score at the bottom after you assess each of these 20 items. And then going back to the full page at the bottom right-hand corner, you'll see some information on scoring. So that's probably why I love this measure, because it gives you some cut points so that you know what that score means. So clinically meaningful pain would be a 14 out of 60. And that would be the point where I think we would suggest an intervention, whether that's a non-pharmacological intervention, like adjusting positioning or massage, things like that, or providing a medication that you've discussed with your provider. And I will note here, mild pain starts at a 10. There are some items there that could mean agitation or spasticity that might not be completely reflective of pain. So that's what we found through research, that pain really seems to start at about a 10. And then I've also provided you the summary graph from the pediatric pain profile. I think this is really helpful, especially in conversations with your provider and your team, where you'll fill out those 20 items for your child at their best. So on a really good day, what does your child's score look like? It might be low, it might still be high, depending on your situation. Then you're going to rank, if you choose, you can rank for different types of pain. So for example, if they have GI pain, you could choose a day when they're having some GI pain and rank their pain total on that day. Then you could look at it for different type of pain, maybe hip pain or spine pain. And then you could track your general pain over time. So kind of putting all three of those together, and maybe you track every day or every couple of days or once a week, and you look at pain overall, which signs they showed. So you might track that over time. And then if you look at with your provider team, maybe putting in an intervention, starting a new medication, or maybe you got the wheelchair realigned, and to look and see if that had an impact. So then you score it as you have been over several time points. And you look for trends. Like in this case, you probably say, well, maybe that didn't really help. Whereas in this case, maybe that intervention really did help. And so I think it can really guide those conversations and give you some data to back up your point of view. You'd be more comfortable and confident with the treatment approaches you're pursuing or not pursuing, depending on what you learn from tracking your child's pain. And just a couple of quick notes. You can, like I said, adjust the frequency and timing. If you have really consistent problems with pain, maybe you'd want to track it at the same time every day and see how it's fluctuating over time. Maybe once a week is good for you, or maybe you have sporadic incidents with pain, and maybe you want to assess when you're seeing those signs of pain, just to back yourself up and maybe decide about an intervention, whether that's something that's a large intervention like a surgery, or maybe it's just whether you're going to give Tylenol or not. Maybe you want to assess the pain, then provide the Tylenol, and then assess it again 20 minutes later and see if it helped. And then, like I said, it can really help to guide those provider discussions. And I think by bringing this to your provider, you help start those conversations about the way they're assessing pain in clinic. I know we have a lot of buy-in at Gillette, and we're making more and more strides in getting this built into the medical record. That really helps. But I know it's a struggle for us, and it's a struggle for every hospital system and even community clinics to know how to assess pain. So I think you can have an impact too by just showing them the way you're tracking your child's pain. So that's all I have, and we'll turn it over to the next presenter.
Thank you very much, Dr. Barney. And again, I'd like to remind everyone that the attachments that Dr. Barney referenced are available for you to download, and we will post them after our talk today. Okay, and now I'd like to welcome Dr. Art Beisang from Gillette Children's, who's co-director of the Rett and Rett-related disorders clinic, who's going to talk to us about pain and distressing symptoms in Rett syndrome. Thanks, Dr. Beisang.
Good afternoon. I'm Art Beisang, co-director of the Rett and Rett-related disorders clinic at Gillette Children's Healthcare. First, I'd like to say I have no disclosures. My part of this talk today is to help identify reasons for physical pain we refer to as nociceptive pain. You just heard from one of my colleagues, Dr. Chantel Barney, who is providing you with a wonderful tool to help figure out when indeed there is pain in folks with Rett syndrome. I wanted to start out with a few definitions today. As I mentioned, nociceptive pain is what I will be talking about primarily. This is pain that can occur from actual damage to tissues in the body, a cut on the skin, a fracture, that sort of thing. And then the signals are then sent to the brain to tell us that we have an injury. Neuropathic pain, on the other hand, is pain that occurs in the nervous system. It may be central in the brain, it might be in peripheral nerves. Dr. Scott Schwantes is going to talk about that more later today and to help us figure out how to take care of that sort of pain. Dysautonomia is not pain, but in Rett syndrome, we find that many of the patients have an incoordination of their autonomic nervous system that can cause distressing symptoms. My colleague, Dr. Tim Fima, is going to talk more about this shortly. It is often frustrating to go to a doctor's clinic or emergency room when you have a child that doesn't speak for themselves and help identify sources of pain. This recent study showed that in our current system, most doctors spend 24 minutes or less with each patient, and of that time, about 16 minutes is focused on the electronic medical record. Obviously, when you have a very complicated patient, this doesn't leave a lot of time to identify sources of pain. So the goal of this talk is to help you figure out what you can do beforehand to make that short time with the provider much more efficient. By the way, I am an old doctor, and so sometimes I use the term doctor when I'm referring to any medical provider such as nurse practitioner, physician's assistant. This slide is a rather busy overview of the whole process from determining there's a distressing symptom to trying to get to the answer at the other end. It starts at home, of course, when you're noticing a distressing symptom. This is where the survey we just talked about can help. If you find that there is a distressing symptom, it's time to start using your observational skills at home to try to get an idea of what's going on when it occurs. At that point, you're going to end up at a doctor's office, either an emergency room or clinic, where you're going to present the symptoms to your doctor. The doctor will go through a relatively standard set of questions and exam, and from that we'll determine testing, and hopefully we'll come out with a diagnosis. Unfortunately, it's not always that easy, and we sometimes need to consider further testing and management, which we've talked about, touched on with dysautonomia and neuropathic. Doctors, nurse practitioners, physicians' assistants around the world are all trained to diagnose a patient in the same manner. We start with a series of questions and then a physical exam, and then we will do testing that is appropriate depending on what we found on our questions and exam. This is important to understand as you go into a clinic visit, and it can make your clinic visit much more efficient. We are hoping with the handout and the next few slides to really prepare you to make those visits more efficient. Before we get into the details, I want to stress the obvious. You are the experts on your loved one with Rett syndrome. You spend hours observing. You have the history in the back of your mind. And in general, we're all pretty smart. You need to trust your intuition. It's very possible that you have the answer at the start of the visit. Don't hesitate to give that to the provider. And many of you have experienced going into a clinic and telling the doctor that your loved one has Rett syndrome, and then they have a blank stare on their face, or maybe they go out to Wikipedia very quickly. You are definitely the experts. It's important to remember that when you're going into these visits. We're presenting a lot of information today. Not all of it can be crammed into a PowerPoint presentation. When I started developing my part of the presentation, it started as a laundry list of different sources of pain to look for. I soon realized this was not going to work and developed this handout, which hopefully will help you prepare for clinic visits and give you some understanding of how the doctor is going to approach pain for your loved one. Also, there is a laundry list of reasons for pain, especially in Rett syndrome, in the handout. It is not an encyclopedia, and no doubt I have missed something in there. My hope is in the future we can continue to improve this document as other people look at it and critique it. This slide shows the general sequence of events that occur in a clinic visit. We start with the history of present illness, and that is really a focused set of questions about the reason the patient presents. Then we expand our list of questions to all of the organ systems, and this is traditionally called a review of systems. After that, generally a physical exam is done. Sometimes the list of questions we've asked will help us focus on specific areas of the exam. At the end of that, we sometimes have an answer. However, many times we have to go on for more testing for confirmation. But in general, this sequence is what you will expect in every clinic visit. So the history of present illness. This is important to think about before getting into the clinic or emergency room. Since we are focused on pain today, many of the questions that the doctor will have when you come to the clinic are going to be about pain. Classically, we ask about the type of pain. Is it sharp or dull? Sharp pain can be a fracture, a laceration, that sort of pain. Dull pain often has to do with abdominal pain. Does the pain come on suddenly, or does it slowly increase? For instance, kidney stones or gallstones can come on quite quickly, as opposed to an appendicitis that can come on with pain slowly. Does the pain come and go, or does it stay there all the time? Those are good questions to think about. Certainly if the pain remains and doesn't come and go, that leads us in a different direction. Obviously, the location is important. If you can identify where that is, that can really help focus the clinic visit. Certainly a femur fracture where you press on one area and elicit the pain every time, or you notice that every time somebody is standing, they're in more pain. That is very good information to have. as a subset of that, can you reproduce the pain with movements or some other activity or pressure? And then just simply trying to identify what makes it better and what makes it worse are great clues. So these are how doctors will often start in a clinic visit. Of course, there will be additional questions in the history of present illness, not just pain questions. Here are some examples of other questions that might be asked by the provider. History does repeat itself, so it's important to think about what has caused pain in the past and bring that up early. Pain tolerance is something to remind the clinician of. They may not be aware that your loved one with Rett syndrome has a very high pain tolerance. After the history of present illness, questions are taken. Many doctors will then launch into a detailed review of systems where questions organized by organ system are asked. This sample is a page out of the handout listing in the first column the organ system, second column what typical questions you may expect to get. Third column are Rett syndrome focused questions that you should also consider. Taken together, this can help move towards a diagnosis. The next step is, of course, the physical exam. This is a head-to-toe exam if we're not quite sure what the source of pain is. It is important to have a thorough exam. And I think sometimes in a busy clinic or ER, if the patient is in a wheelchair and they're hard to get on a table, we sometimes don't have a thorough exam in the diaper underwear area. It's important to insist on an exam in this area, looking for pressure ulcers and other signs of infection. The physical exam is a very important part of the clinic visit. Generally, if we don't have a source of pain, it's going to be a thorough head-to-toe evaluation of the patient. Sometimes, if we've been able to narrow down a source of pain on our history, it'll be more focused. This slide shows some of the areas that the doctors would be taking a look at and some of the specific issues they'd be looking for. This is not an exhaustive list, but more frequent in Rett syndrome, we see issues with G-tube irritation, constipation, and gastritis. Also, bone health is a very important part of Rett syndrome care, and we're always looking for occult fractures. We, of course, go on to do testing in many situations. Here is a list of tests that are once again out of the handout. There are certainly many more tests than on this list. These are the more common tests that are obtained, kind of the reason why we do that. And then once again, in the third column, some specific considerations for Rett syndrome. When we consider testing, it's both blood tests and urine tests from the previous page, but also imaging tests. They can be very helpful when we're not sure where the source of pain is coming from. Certainly x-rays looking for fractures is pretty obvious and done quite frequently. Evaluation by ultrasound and by CT scan looking for obstruction of the gallbladder and kidney stones is quite frequent. And depending on our history and physical exam, we'll be directed towards some of these tests. Once again, out of the handout, list of the imaging tests, common reasons, and some of the specific considerations in Rett syndrome. Patients with Rett syndrome are, of course, going to have the common reasons for pain that any other patient would. In the handout, we've listed many common reasons for pain, how they present, and what the treatment is. Certainly, as you're at home thinking about why a patient with Rett syndrome has pain, we need to think about these more common reasons. At the same time, we're thinking about the unique reasons that a patient with Rett syndrome may have pain. Here's a list of some of them. Once again, this is not an exhaustive list, but some of the more common reasons. In addition to the common reasons for pain, patients with Rett syndrome have some very specific reasons for pain that need to be considered in a clinic visit. This slide lists some of them. In the handout, we have a more detailed list of reasons for pain in Rett syndrome, some of their presenting symptoms, and what to test for. I just wanted to point out a couple of these. Certainly, bone health is a big issue in Rett syndrome, and we're always concerned about occult fractures. Gallbladder issues occur at a much earlier age in Rett syndrome. Most physicians do not realize this, so it's important to point that out. Renal stones occur frequently associated with seizures, with a ketogenic diet and seizure medications. We certainly see some gastritis related to dysautonomia, and of course, air swallowing in a subset of girls and women with Rett syndrome can be really quite distressing. Well, we're almost at the end of my portion of this talk. My whole goal today was to give you an inside baseball look at what the providers are thinking about and the questions they're going to ask before you get to the clinic visit. This will allow you to have a much more effective visit and hopefully get to the source of pain in one visit instead of many. I wish I could tell you that we can diagnose the source of pain 100% of the time, but in reality, we're probably closer to 30 to 50%. That's why we need to think about other reasons for distress, such as Rett spells and dysautonomia that Dr. Fima will talk about, and neuropathic pain and how we can treat that. So once again, thank you. I hope you were able to pay more attention than.
Sorry, Dr. Beisang. Okay, I am so grateful for that talk, and I know these little ones might not have stayed awake for
These three. I look forward to.
There we go. But I know everyone in the audience was listening with, let's see if you can turn your microphone on. I think you might be muted.
Hello.
There we go. There we go.
Let me see if I can share my screen. I pre-recorded that talk, not sure if I would be able to be here at this point. Fortunately, I am. Unfortunately, my colleague, Dr. Tim Fima, wasn't able to be here today. He had some acute patient emergencies at the last minute. So I am going to talk a little bit more about dysautonomia. So you will have to put up with me for just another minute. I'm getting the next PowerPoint up here.
Sure. And while you're pulling up, I just want to thank everyone for your great teamwork today. We're working across 3 or 4 different institutions, and it's a real testament to how collaborative our work is together across RettSyndrome.org, the West Rett Syndrome Foundation, Gillette Children's, University of Minnesota.
So I think I just messed that up.
Okay.
I hit, I think, duplicate my screen instead of show the one screen.
There we go. You're good. We're at definition, National Institute of Health.
Okay, well, that's good. I can't see it, but I'm glad everybody else can. So I just need, oh, there we go. I think I can.
You know, I know this is all tricky.
This is really a smooth transition, isn't it? So I'm going to talk about a little bit about dysautonomia. This is the National Institute of Health definition. Actually, it's only the first paragraph of it. It's about a page long. I don't bring this up to have you memorize the definition. I bring it up more or less to say that it's a very confusing definition, and most practitioners think they know what dysautonomia is, but the definition is argued about all over the place. So I'm going to give you my take on what dysautonomia is. Before I do that, I'm going to keep you in suspense. I want to talk about the autonomic nervous system. Not very long, but so the autonomic nervous system is that part of our nervous system that we don't really think about. It controls our breathing, our blood pressure, bowel and bladder, all of those things, temperature. Fortunately, our body's a pretty amazing organism, and we don't have to think about it at all. It has really two parts of it. It has the sympathetic and the parasympathetic. And the sympathetic nervous system is really the part that prepares us for emergencies. We've all heard of the fight versus flight. And so when we're very nervous, we come to a very stressful situation, like being chased by a dinosaur. We rev up our heart rate. We divert our blood from the skin to the internal organs, and we're very stressful. The parasympathetic, on the other hand, is the calming part. That's the part that after we're done being chased by the dinosaur and we're hiding safely, we relax, our blood pressure comes down to normal, we start our normal daily activities, our breathing is comfortable. So those are the two parts. And this slide really kind of looks at the autonomic nervous system. So over on the left side, we have the parasympathetic, which is the part that is the relaxation part. The right side is the sympathetic. And you can see both sides will affect all of our internal organs. Our lungs, our heart, our intestines, our bowel and bladder. And it's very important to kind of understand that. In a person who is doing well and functioning normally, there's a balance to all of those organs. If there is not a balance, we get dysautonomia. And in Rett syndrome, the nervous connections in the back of the brain are not integrated perfectly, and we have an imbalance. That's why we see hyperventilation and breath holding, increased heart rate and prolonged QT syndrome, and why our extremities get hot and cool in Rett syndrome. We also see a lot of gastrointestinal problems with the gallbladder and digestion being a big problem, and also urinary retention. So that's really, when you think about dysautonomia, you think about the parasympathetic and the sympathetic systems not in balance, and that's where we get a lot of our distressing symptoms in Rett syndrome. This is a picture out of a paper that Dr. Simons and our Gillette crew did a few years ago. This looks at one of our patients with an infrared photo. So the infrared is looking at heat. And you can see with the right leg, that foot is very hot and the left leg is very cool. This is all the same person in the same time. So this is a very good example of how the dysregulation of our autonomic nervous system is upsetting to our patients with Rett syndrome. This is a very busy slide. Dr. Schwantes, who's going to speak next, is probably rolling his eyes because he's the master at PowerPoint presentations. But I wanted to talk a little bit about gastritis, a little more than I did in the last section. I find in my practice, a lot of patients with Rett syndrome who are having distressing symptoms will end up with gastritis. And really it has to do with when the bowel and the bladder aren't functioning normally, where we have significant constipation or we have significant urinary retention or breathing issues. All of that will trigger increased stomach acid being secreted in the stomach and causing ulceration, which is quite painful. And I find by doing a simple gastric pH, I can oftentimes diagnose that. The official way to diagnose that is with an endoscopy, but if you have a patient with a gastric tube, we can sometimes just pull the fluid off and identify a very low gastric pH and then start treatment. I guess my PowerPoint is telling me I have to speed it up. So what we like to do then is recognize what's triggering the gastritis. Is it constipation? Is it urinary retention? Something else that is stimulating the dysautonomia? Try to take care of that first. If we can't, then we go ahead and use medication. And we'll talk more about that with Dr. Schwantes. This is my last slide, you'll be happy to know. I wanted to talk just a little bit about Rett spells, and Dr. Feima is much more expert in this area than I am. But Rett spells are not defined very well either. Often they're distressing periods of time for a patient with Rett syndrome, and often they're hard to distinguish from epilepsy. So it's often we use video EEG over a period of days to try to capture those spells and then be able to distinguish them from a seizure. Nobody really knows what the mechanism is, and if you get 7 neurologists in a room who deal with Rett syndrome, you'll get 8 answers. But most people agree it seems to be some sort of brainstem discharge causing the Rett spells. And since oftentimes people are looking quite frightful, often with really fast respiratory effort, we think that it might have to do with a discharge from that sympathetic side of the autonomic nervous system. And we use clonidine sometimes, and that seems to help in our practice. But I will leave the final discussion on that to the experts. Thank you very much for putting up with me for another short section. And Dr. Schwantes will be talking more about taking care of pain. Let me unshare my slides here.
Thanks, Dr. Beisang. We know that this is such a complex topic, and we appreciate everyone's assistance in helping us muddle through. I'd now like to invite Dr. Schwantes, who is a pain expert.
Hello, everyone. Pleasure to be with all of you today. First of all, thank you for being here. It's great that you're obviously working on learning more about how to help your children and other young adults with Rett syndrome. So I'm just happy to share the presentation and be on this distinguished panel with everybody else here today. My name is Dr. Scott Schwantes. I'm a pain doctor at Children's in Minnesota. I used to work about 10 years at Gillette before I crossed the river over to the Minneapolis side of things. I just wanted to take the time, like I said, to really just give a bit of a background on what happens when and if you actually get to the point of being referred to me, a pain doctor. So first off, I just want to help understand a little bit about pain in general, and then more specifically about what I do to help provide relief for pain in children going through painful experiences. One of the things I would like to point out is that pain is terribly subjective, and sometimes people have it in their minds what pain is. So I like to use the broader term too of pain or distressing symptoms. If your child's in distress and just isn't right, we're here to help. To the degree possible, I always like to advocate for the fact of just quickly retelling the story of the lion with the thorn in its paw. That's the one where the grumpy old lion is stomping around the forest and nobody goes by him because he's so grumpy, until one day a brave little mouse goes up to the lion and says, "Hey, do you know you have a thorn in your paw?" Lion looks and goes, "Oh," boink, takes the thorn out. Now the lion's happy. So everybody gets along in the forest. The only reason I'd like to tell that story when discussing pain is because, to the degree possible, and this is what Dr. Beisang was talking about, it behooves us to try to identify and remove the thorn in the paw. And that's clearly the role of a lot of the investigations that Dr. Beisang was talking about and the treatment thereof. If unfortunately we've engaged in that reasonable workup and your child is still in distress, then we have to say, well, what else can we do about it? And that's where I can come in to say, what is my approach to dealing with children in pain? Looking at that, I just had a quick little disclaimer because I'm married to an attorney. First, I just want to go through an understanding of pain and pain pathways as we understand it. One of my boarding institute academies is the American Board of Hospice and Palliative Medicine, and this is how we understand pain. First, you have the transduction phase, which is where you take an external signal and you convert it into an electrical signal, and that starts the pain process. So this is usually in the periphery. After that, the pain signal has to travel up the nerve in the part that we would call conduction, and then it would eventually go to the spinal cord, where it hands off from that peripheral or body nerve to the central nerve that goes up to the brain. That part is called transmission. The majority of my pain meds work here at the transmission site. After that, it goes up into the brain and has this little series of synapses where you finally obtain the perception of pain. And then we also know that we have the ability to go through what we call the descending inhibitory pathway, and this allows us to modulate our sense of pain. I think of sort of 4 types of pain when I approach patients with pain. First is that somatic type pain. This includes that external pain like a broken bone, a cut, an injury, as well as some of those internal type pains like visceral hyperalgesia or kind of that GI pain. After that is inflammatory pain. This is usually the pain in the joints that can be set up from either arthritis, as obviously the most typical example, but this can also happen to some of our children with tone issues that have a constant strain or pull on some of their joints. Those first 2 types of pain, inflammatory and somatic pain, are both good pain because they warn us of that real or impending tissue damage as sort of a signal that something's wrong. We also have no good pain that serves us no good purpose, and one of those is that neuropathic pain. This is often that pain that is described as numbness or tingling or burning or a sensation of electricity. And it's just very disconcerting for folks to have. In our children who are nonverbal, this is sometimes just identified as difficulty trying to get comfortable. They're just kind of irritable and just can't really seem to find a comfortable position, and just really having a lot of distress without an apparent known cause. After that, we do have central pain. Frank Simons alluded to this a little bit as well. This would include some of our chronic pain syndromes, or sometimes more specifically to children with Rett syndrome with repeated exposure to painful stimuli. They end up with this piece of what we more accurately call central sensitization. And this is definitely where we have to take on different modalities. Again, I talk about this just because they help me structure my approach to the pain management. Specifically around some of the children with Rett syndrome, this was from a fantastic study by Dr. Chantel Barney et al. In 2015, but we know that a lot of kids with Rett syndrome experience pain. And in this study, they noticed that 89% of the children in their survey had experienced pain within the last week. And this was kind of more called out as gastrointestinal pain, musculoskeletal pain than what they called seizure-related pain. There was another study done, I believe, just of parents of children with Rett syndrome, and those parents would often identify either external pain for their child or internal pain for their child. And that generally broke down to more of that musculoskeletal pain as that external pain and that gastrointestinal as the internal pain. And then what makes the kids feel better? These were what were noted to be the effective modalities in that study. Medications do play a large role. That's a lot of what I do, but we also know that there's a lot of non-pharmacologic management for our children in distress. Massage and distraction were both noted to be quite beneficial to children that were going through some of these painful situations. I share this wonderful picture of Dr. Frank Simons once again, because there is obviously a lot of ongoing research into Rett syndrome as well. And anything that he tells you trumps you anything that I might tell you about this part of it. But what we do know about children with Rett syndrome is that there is some evidence along the MECP2 gene and how that relates to pain sensitivity. And by and large, children with Rett syndrome are less sensitive to pain. They have that higher pain threshold. They just have that decreased sensitivity to pain, and that may have something to do with the aberration of the MECP2 gene. Okay, so, and again, I apologize. I am talking quickly and trying to go through this because I want to leave plenty of time for questions, because I want you all to be leaving with as full of cups of possible for your knowledge base. When I approach the pain plan for the kids, I always think about what I call multimodal analgesia, because it's not just throwing one drug or another at you, it's thinking carefully about all of these types of avenues to try to improve your child's disposition. So we'll go through each of these in a little bit more detail. Simple analgesia is very appropriate to consider for all of our kids. This includes these medications, acetaminophen, the NSAIDs, and celecoxib for the children that can't tolerate the traditional NSAIDs. All of these are worth trying and definitely worth considering. And definitely when we do a post-operative pain management plan, since we did talk a little bit about procedural pain, I always include the simple analgesics as part of my pain plan because we know that they are opioid sparing. So if a child after a surgery is on these agents in addition to an opioid, they will use less opioid than a child who is not on these agents, and that's generally a good thing. Opioids, though, are very appropriate. You can have them by mouth, by IV, and there's a bunch of opioids that we consider. Won't get too far in depth here unless somebody has a greater question. Other than recognizing that for children with Rett syndrome, I do get a little concerned about the use of tramadol and the use of methadone. Tramadol can lower the seizure threshold, and therefore I will consider not using that in a child with Rett syndrome. And I would very cautiously approach the use of methadone in a child with Rett syndrome because of the risk for prolonging QT interval or that cardiac or heart arrhythmia. So although opioids can do great when they're well indicated, and generally that is when a child is definitely showing us signs of ongoing tissue damage, that's when opioids are appropriate. These can be helpful medications, but again, these two I would use with caution. If you're on regular opioid use, we do talk about side effect management because we know you're going to have side effects from opioids. If you're in the hospital recovering from surgery, I will always start a naloxone infusion if I have you on higher dose opioids to control the pain, and that's to mitigate some of those opioid side effects. If you're on chronic opioid therapy for one reason or another, we know that constipation is the one side effect that never gets better with opioids, so we definitely make sure you have an excellent constipation plan in place, especially if I know I'm going to be making that worse with opioids. Adjuvant analgesias are also very appropriate to use, and this is stuff that is other medications to treat some of these other distressing symptoms. Benzodiazepines come up a lot. This is more for a hospital-based approach, but those can have a role in an outpatient or ambulatory setting as well. A lot of these other adjuvants work great when I'm concerned more about the neuropathic pain. If I said I've ruled out any reasonable cause of somatic pain, yet pain or distress is still present, I'm going to think about neuropathic pain. Generally, I will go to the gabapentinoids, which include gabapentin and pregabalin, simply because they play nice in the sandbox with other drugs. They only interact at the calcium 1 ligand 6 channel on the presynaptic nerve, but essentially it's a gabapentin receptor. Nothing else uses that receptor. So that's why it can be very helpful because, again, it doesn't have a lot of cross problems with other medications that your child might be on. These are some of the other things that I would also consider depending if I was caring for your child in the hospital or in the clinic type of a setting. we do have to pay attention to the role of antidepressants. This has a little bit of a review in the literature for young adults with Rett syndrome, and then other young adults with impaired cognitive or developmental delay or intellectual developmental delay. If we only assume they're having pain and yet they're in this continued distress, we should consider that they might actually benefit from an antidepressant. And these are other times that we would introduce these very carefully and after a close conversation with the family. As Dr. Beisang alluded to, and I definitely wanted to support, you will always know more about your child than any of us ever will. Even though we may claim to be experts in our field of experience, you are the expert in your child. So if you're raising concerns for persistent distress, I'm going to be thinking about that carefully, and I'm going to consider some of these other adjuvants and what they might be treating in your child's best interest as well. In more of a surgical type setting, again, knowing that our young adults with Rett syndrome in general have that higher pain tolerance, and if we know they're undergoing a painful procedure such as a big hip surgery, we might use regional anesthesia to essentially do like an epidural or a block to help them recover from that surgery, just so that we know we're giving them excellent analgesic control in that postoperative setting. Non-pharmacologic interventions, though, are huge, and I definitely want to endorse that these are very appropriate to always be considering as part of any of the pain plans that you might receive in either that clinic setting or a hospital setting. Distraction is wonderful. I've had so many kids with their iPads or their tablets that just focus on that, and it's like, that's fantastic, go for it. But we also want to pay attention to some of these other areas that may be very appropriate for the child to be paying attention to. We can also work with families to teach some of these things if you needed it, or if you would find it beneficial, so that it can continue to be given in the home setting. And then the integrative medicine modalities, more specifically, these can also provide a great deal of relief. And we definitely want to use these things to the degree that they're helpful, and they can prevent us from using other medications that may have their own side effects. All of these are wonderful things to just, again, help a child be more comfortable. I always include family support because it's a unit. We don't see our patients in isolation. We know our kids come with their families. And sometimes there's a lot of other stuff that we can do to support the family. And if we can do that, then that will allow you to do what you're supposed to do, which is be your child's parent. So if we can help make sure that you have all the appropriate resources to be successful in your home community, that's a big part of what we can do to improve the overall life and well-being of the children that we're charged with caring for. Like I said, I've did that pretty quickly, but I mostly wanted to make sure that we had time for questions, because I think that's where I really want to help focus on what I can do to help you guys out. If you do have a question, I am bravely sharing my email out there for all of you to attend to. If you do decide to email me, please do so, but at least in version of, hey, I was part of the RettEd talk there at the end of April, just had a follow-up. And now I think we're going to be turning it over to the Q&A, and I'm going to give my screen back to Paige at this point and hide my content. Thank you all so much.
Great, thanks, Dr. Schwantes. Okay, well, everyone, that was a marathon of really dense information, and big disclaimer or reminder, actually, that the session is being recorded, so you'll receive a link to the recording and you can go back and reference this, the talks today, and share them with people that you're, struggling to tease out your child's issues with. And we do have about 20 minutes, though. I'd like to invite all of our panelists to turn on your webcams, and we will go through some questions from our audience. Thank you so much. Okay, thanks everyone. All right, so going back to the beginning of our talk, Dr. Barney, we've got a couple of questions for you. Okay, should we go last to first? I think we'll go first to last. So we have a very good question from a parent who asks about rating pain. How do we know our girls have pain versus a bad attitude? How do we differentiate their moans, facial expressions to even begin to rate it as pain? And everyone is welcome to reply, but let's first hear from Dr. Barney.
I guess that's why this, especially the second scale, is helpful, because it does give you well-validated and reliable assessment, things to observe and score on your child's behalf. So I guess I would caution against assuming that some of those things would be not reflective of pain. Like I said, it has to reach a certain point, like the 10 out of 60, to be considered mild pain. So maybe a lower score or a score in that mild range might be confused as other things, but I think when you get up to the higher scores, it's been clinically shown and research to back it up that scores at that cut point of 14 or greater would be pain, clinically important pain to manage and treat. I don't know if that fully answers the question, but it is definitely hard to tease apart different behavior signs, and I guess that's why there has been a history of difficulties assessing pain in nonverbal populations.
Thank you. You know, there's another question in the queue that is somewhat related to a part of this specific question, which is about generalized moaning and groaning that we see in some of our children, and particularly I think as our children age into adulthood. Kind of can sound like a humming, can sound like a moaning. Dr. Beisang, Dr. Schwantes, Dr. Barney, do you have experience with these patients? This would be anecdotal of what you've seen and how you've helped families say, is this just something that is what she can do and is not really expressive of something, or should they be seeking really some more intensive differential about if it's a chronic pain, a persistent pain?
That's a tough one. We do see a lot of kids that will do a kind of a very low sound or even bruxism, tooth grinding. And when you think about it, it does cause a real vibration within the body. And sometimes that's a nice self-stimulation that occurs. So we see that with a lot of kids. And it's not necessarily pain, but more self-stimulation. And if you can distract them with something else and the moaning or the tooth grinding stops, then you usually have a good indication that it's not pain related. I don't know if that helps at all.
Sometimes I would say when we're working with children and young adults who are typically nonverbal, the question would be, how do I interpret what my child is doing? And again, I would definitely lean on the fact of your parent radar is a pretty strong tool. If you perceive this as distressful, then that's something that I would want to do something about. If you feel like it's causing distress in your child, that crosses this threshold. And I like to use the more subjective terms in this case. Because it's like, I want to help out with that. Versus like, gosh, she's really doing this moaning and stuff, but she's fine. And it's like, well, maybe this is more of just a self-stimulatory type of a behavior or some way of interacting with their external environment. So if it's not distressful, then I'm less likely to come up with some sort of a distressing symptom management plan. But I think a lot of the work that Dr. Barney has also engaged in is saying, we do have some tools that parents can have if they want to try to apply an objective criteria to subjective symptoms. And I think that's definitely a benefit for some of the families. That's a great resource to have, because then it's like, I feel like I can do something. I can score what my child is going through, and that helps me tilt the balance in as to, would I then call this pain? Because as Dr. Beisang has pointed out too, we're here to help, and that's what we want to do, but we also don't want to over-medicalize what might be typical behavior. So to me, it is a little bit of that subjective feel of, is this actual representation of distress, or is this just some way of engaging in the environment? For the appropriate families, I think Dr. Barney's tools, again, are wonderful tools to say, and we do have things that can provide some objective data to this subjective experience. So I think it's kind of one of those all of the aboves. But I would definitely say, as a clinician taking care of your children, I yield a lot to the parent radar, saying, is this something that's concerning to you? Or is this something you just wanted to talk about? And I definitely, like I said, it's not your job to doctor your child, but at the same time, your parent radar is a strong tool to have.
And would you say, Dr. Schwantes, there be risk in maybe scoring your child's pain as a reflection of having that score at the front end, and then trying some intervention that you've discussed with your provider, like an NSAID, and then scoring it again later, kind of as a sample size of one?
And I think that's great too. And this is a wonderful thing too, is when we do look at all this wonderful research, that's population numbers. What's most important is how does your child respond to our interventions? I think that's, again, as Chantel was pointing out, that's a great use of the tool too, of saying, we're going to do a score, do an intervention. Did it make a difference? Yes or no? And that's sometimes how we approach our work too. It's like, if this was pain, Tylenol or ibuprofen should have made some bit of an improvement. If those didn't make any improvement, then it likely wasn't a somatic type pain. And sometimes we use that sort of approach too, saying, if it's this, this should work. If this didn't work, it likely wasn't this. So sometimes those are tools also that we can use to just have a little bit of an algorithmic approach of saying, I just want your kid to feel better.
Thank you. I'm jumping around a little bit because you're saying things and it triggers my recognition that there was a question related in the queue. And one parent asked about their child, how long do you wait before trying a medication such as Tylenol? So how long do you let your child cry before trying something to test if that works? And then how long do you wait to say, yes, this is working or not working? I understand as a parent, you get pretty stressed in those moments. So I think parents are just looking for some guidelines to help know when to pick up the phone to call somebody and what to try at home. So sometimes the stopwatch gives you some good guidelines. What can you say?
Well, I think we're going to go back to the parent radar a little bit. Most parents understand if their kids are truly in pain or not. And if we're going to try Tylenol, another pain medication, we know in a half hour to 45 minutes, it's going to start to have some effect. If it's not working within an hour, well, then we should keep thinking about what else is going on. If the pain is getting worse, if there's a fever associated, then I wouldn't hesitate going to the clinic or emergency room a little sooner in that situation.
Yeah, I think there's definitely a bit of a difference of an out of the blue type of event, like we're cruising along doing our thing and all of a sudden at 5 o'clock on Tuesday afternoon, things really got out of control. That's definitely more of an urgent type of a situation, I think, as Dr. Beisang was saying. Those generally require a little bit of a different approach. I'm usually a little bit more downstream, so by the time a kid is coming to me, it's usually because they're in pain. So at that point, then we'll kind of just come up with a distressing symptom protocol. Often when we do that, I'll talk about what are the medications that I might prescribe that you would take 2 times a day every day or 3 times a day every day, just baseline as a controller, versus what then do you do during a heightened period of increased crying or distressing behaviors. Typically what we'll craft at that point is engage in non-pharmacologic activities first. Try distraction, try checking to see if they've got a wet diaper or whatnot, try repositioning, try this. And you do just the non-pharmacologic things first. If those didn't improve the symptoms pretty quickly, then it's usually give Tylenol and ibuprofen. Wait 15 to 20 minutes. If not any better, try a PRN dose of diphenhydramine or Benadryl. This is a generic plan. It would be obviously tailor-made to the specific child. Wait 15, 20 minutes, give a dose of Valium. Wait 15, 20 minutes, give a dose of oxycodone. If still in distress, call your provider. So that's often what we'll do is we can get as specific as saying, this is your protocol for saying, I don't know what else it is. I talked to Dr. Beisang. We ruled out acute causes such as fever. I'm going to go to my pain plan. And this would be sort of, we can craft those types of distressing symptom protocols. But like I said, we balance that with the pharmacologic stuff we know, like what we call pharmacodynamics and pharmacokinetics. The medicine should work by now versus how long are you going to sit there and wait while your kid's crying. There's a little bit of a both and, but in general, like I said, it would be for pain, not for dealing with the acute stuff that Dr. Beisang has to deal with, would be do your non-pharmacologic stuff first. If you're not better, give a dose of Tylenol and ibuprofen at the same time if you're allowed to. Wait 15, 20 minutes, give your next med, wait 15, 20 minutes, et cetera, et cetera.
Okay, thank you. Thank you for sharing that information. And back to Dr. Barney, we have a question about the pain assessment scale. So someone is saying that unable to assess has the same scoring of 0 as not at all, and is wondering if that could skew the pain scoring and underrepresent the severity.
Yeah, I worry about that too. Hopefully you can find a timing that works for you. For example, if you were to assess every day, like once a day, looking back at the last 24 hours, you should be able to assess both sleep and eating, the ones that are most commonly not able to be assessed. But I think if your child is in, clinically like that relevant pain of 14 or greater, you're going to be able to have enough other signs to reach that score of 14 out of 60, even without being able to assess certain other ones, because those are the two that really come up in clinic as not being assessed easily. But we do the 1 week time frame, so we generally don't have too many people saying they couldn't assess those. But I can certainly see how in like the last 15 minutes, if you're going to do something like that in acute episodes, could cause problems. But I think if it's that scenario where you're looking at an acute episode of pain, you're probably, if it is pain, you're going to see enough other signals of like distressed face, holding your body in a certain way. You don't have to get too many signs of pain to get to 14. So I think it's still, it's still shown great psychometric properties and in relationship to clinical assessment and parents reporting in other ways, whether they thought their child was in pain or not. It has stacked up very well compared to those of that gut instinct and then like a precision instinct of whether the child's in pain or not. And it's reaching that 14 out of 60 if those all align basically. So having said all that, try it out. If you do have a lot of things that you feel like you can't assess, certainly reach out to me. I'm definitely interested in, this isn't my scale, but improving the way we assess pain so that it works for everybody, including girls with Rett syndrome. So.
Thank you. We really appreciate that. And I know that you mean that sincerely and genuinely. So we encourage everybody with these scales, try to use them in regular life and give us feedback. And I'm happy to connect anyone with Dr. Barney to get some better, tighter information on how to use in our population with Rett syndrome. Okay, another question, and this is very common and something that I've experienced and seen frequently with many kids with Rett syndrome, but specifically a parent is saying, almost without fail, their child comes out of sleep, whether it's a nap time during the day or waking in the morning, just crying, distressed, upset. Generally, get her settled down, feed her a meal, and she'll settle down. But that period of just really distressing behavior is very upsetting, and the parent is wondering if there's anything that they can do from your experience to say, is she experiencing pain? Is it just dysregulated expression? And any thoughts on how to help her?
Yeah, that's a very, very hard one to answer, of course. I think when I think about that situation, if it's very consistent with most periods of waking, I'm thinking about either pain that is repetitive or it's not pain, quite frankly. And there's very few things that will cause that pain from sleeping unless, let me go back. If people are waking up at about the same time every day, so they're not waking in pain at different times of the evening, I'm not as worried about it. Could it be something like reflux? Absolutely. But if it's a consistent pattern every day, it's probably less nociceptive pain than it is just a distressed person. That doesn't really help, but if they're getting over that distress very shortly every day, for me, it's not quite in the same category as significant pain that is waking people at various times through the night. Then I have to think about, musculoskeletal pain that's causing trouble, reflux, that sort of thing is where I would start investigating. Please jump in.
When I hear about, I mean, obviously going to be concerned about pain. Is there something that, you know, were they positioned poorly? Is they've got some sort of contracture or something else that might have just caused them to be painfully awake? But the other thing I would lean a little bit would be some of the neurologic causes as far as like those transitions from sleep to wakefulness. Is there some element of underlying neurologic difficulty, whether that is actually an expression of stress, anxiety, depression? Those could very well be well and true, versus some sort of dysregulation period as well, just as you're going through those periods. Dr. Beisang talked about dysautonomia, and when we look at that, some of the other models for that talk about the imbalance between the excitation inhibition ratio. And that just basically means how well do the different layers of the brain talk to each other. It's usually like a pretty fluid brake and accelerator system, but in kids with dysautonomia, and especially in Rett syndrome, when it's a neurologic dysautonomia, those brakes and accelerators are not smooth. So sometimes that could be more of an example of a neurologic origin, just with that transition from a period of sleep to a period of wakefulness. So those would be some of the other avenues I would consider, in addition to, as Dr. Beisang was talking about, is there an underlying painful pain presence, whether it's musculoskeletal pain and they were positioned poorly, something like that, or is it more of a neurologic etiology or even psychiatric behavioral etiology?
Thank you. Okay, we're starting to reach the end of our time. I think there are two questions though that really were thematic in the queue, and I will distribute all of the questions in the queue to our panel, and we'll develop a QA doc and share that back out for everybody. Because we are limited in time, and you know, this is just, it's such an emotional topic. You're doing a great job helping parents settle in to say, okay, some of this might be behavioral, and if I can feel confident that's what it is, then we can work with that. But if she's feeling pain, it would just be a terrible thing to not be able to help. So I think that's the beginning, and that's what the pain scales help families to be able to do, and have vocabulary to talk to their providers to help in that journey of differentiation. One thing that is very important, I think, from a medical perspective, and Dr. Schwantes, you mentioned this a little bit in your slides, is the experience of long QT and the concern of some medications. Specifically, we have an attendee asking about diphenhydramine. Diphenhydramine,
Benadryl, yep.
Thanks, okay. Benadryl, yeah, we all know that one. Okay, and that is on the prolonged QT list. So that was one of the medications you recommended, but let's just talk about long QT for a moment and things that we should be aware of, and call out to our providers who may not be aware of long QT syndrome incidence in Rett syndrome.
Well, there is an increased incidence. We'll start there. That's why we like to evaluate every year. Certainly, the autonomic nervous system with increased sympathetic tone will prolong the QT syndrome. And so there are some questions about once you have QT, do you always have it? How serious is it? And I don't know that we have great answers for that. I think it's important to recognize, and if we do have prolonged QT syndrome, we need to respect that. There are some medications we still have to give because the benefit of the meds far outweighs the risk. So in those situations, talking with the individual provider who's giving the medication, you need to consider that. But in general, yeah, we don't like to give out medicines that prolong the QT syndrome or the QT interval if we don't have to. But frequent checking is important, and there are some mutations that are more at risk, it appears, than others for prolonged QT syndrome. So in those cases, maybe a little more frequent checking, but there is no absolute consensus on what to do with that I'm aware of.
And I think it's just being aware that what are the children and young adults with Rett syndrome at risk for about population. And how do you engage in that mindful monitoring of that? And that is why when you go to an experienced Rett clinic like the one that Dr. Beisang and Dr. work at, they're going to be checking those things for your child on an annual basis. And then it is just being careful though, like if you do have to go to the emergency room for something and they prescribe a drug or medication and you want to, maybe you have to advocate for your child and maybe you just want to run it past one of your Rett team's members as well, because if you go and you're diagnosed with a yeast infection and they give you fluconazole, is that going to put you at risk for QT prolongation? Those are some of the things where you should always feel comfortable going back to your Rett team. And as Dr. Beisang was saying, sometimes we still use medications knowing that they are in a risk category because, as he stated, we believe the benefit outweighs the risk. But that's always a conversation that we have. You should hopefully never have just your doc saying, here, take this medicine. And you're like, wait a second, did we talk about this? Because they should be able to articulate. Because I definitely have prescribed methadone for other patients who had the presence of cardiac abnormalities because that was the best drug for their stage of life. But it was through a thoughtful conversation. And Paige, I just wanted to quickly dovetail off a comment you had made, kind of, I think, catching the vibe of what some of the families were talking about, like, if it comes down to the conclusion that this is behavioral, then I can deal with this, but I want to rule out everything else first. I would also just like to reinforce, even if it is behavioral, we can partner together on that. You're never going to be alone in this journey. We're always going to be here to help. It's just that if we come to the conclusion that this does appear to be more psych behavioral in nature, let's now talk about what this approach will look like. It's not like I'm going to say it's behavioral, you're on your own. It's just a different conversation that we're then thinking about what's the best way to improve their overall well-being. Because again, never should you have to feel like your child is suffering. And again, that's a vague term, but I like it because it is vague, because if you're left with some version of, but my child is suffering, then that behooves us again to say, let's work together, let's partner to find a way to improve their quality of life such that it is meaningful in the way that you define by your family's goals and values.
And Dr. Schwantes, that is why we have you on our talk today. Very, very kind way to approach many of these issues in our children who are nonverbal. And we don't want to just accept suffering in any way, whether it's physical, mental, emotional. So I want to close on maybe more of an optimistic note for our families who are beginning a journey of communication. We have a couple of questions about your experiences with equipping our children who are nonverbal but are maybe using AAC, eye gaze devices, with some vocabulary to express themselves, what they're feeling and what they're needing and what they're wanting. Can you comment on that? I do have some slides that one of our communication specialists provided. I'm not going to go into a long talk. I'm just going to show some screenshots, if you don't mind, while you talk about that.
Yeah, I really support whatever we can do using any sort of additional tool. Many of my patients use eye gaze and it works really well. A lot of my patients find that eye gaze is tiring. And instead of just putting it in the closet, I suggest that people then try to use a written version that they can look through with a booklet. And I think either way, that can really help point out where the source of pain is coming from. And certainly we don't want to start during the episode of pain, because we're not going to, it's hard to learn anything. And then when we're in a distressing situation, trying to learn how to use the eye gaze for different pieces for pain is very difficult. So starting early as part of the education, looking at anatomy, for instance, is really very beneficial. And then talking about their feelings can really help us to distinguish between pain and frustration and anger. So I'm a big supporter of eye gaze or any other way to get across graphically what's going on. So that's all I have to say on that.
I would just add that in research studies in other populations with complex disabilities that now it was a shorter term training rather than months. It was several training sessions that children seemed to be able to understand the concept and could perform fairly well, but then in a pain situation, they couldn't perform as well. So I just encourage parents to also rely on other means of assessing that pain, because I think for all of us, well, I know for all of us, when we're in pain, we don't function as well. We don't have the same IQ that we do when we're not in pain. So it's good to still look at those other distressing symptoms.
Yeah, I endorse what Dr. Barney was saying and Dr. Beisang too. These are great. I love when kids find a mean to just unlock their worlds a little bit better. It's so cool to see. But at the same time, don't turn off your parent radar. If you're just like, but my kid's saying this using their device, but I'm seeing that they're in significant pain, you know, stick with your mom radar or your parent radar as well and just be like, okay, we're going to still do something about this. Because as Chantel was saying, you may not be at your best if you're having a painful episode. So they're great tools, but don't use that as a surrogate for your overall parent radar as well.
And I think, you know, what we're really talking about in all of this is trust your judgment, prepare before you go see a provider. If you can think about the source of pain, where it's coming from, what relieves it, and go into a visit with that sort of information, it's going to make the visit so much more effective for you. So rather than bouncing to 3 doctors, you might get what you need from the first doctor. So, and I just want to put in a pitch for the handout again, because there's a lot of detail in there that can help you prepare for a visit.
That's right. Dr. Art Beisang, hardest working pediatrician at Gillette.
So thank you so much for those handouts and attachments. I know everybody's frantically downloading them. We will upload them to our website and we will share them. Thank you for producing them specifically for this talk, Dr. Beisang. It's very long overdue to have that available, and I know it will be shared widely beyond today's meeting. We'll be sharing it at the summit and at all future meetings. And Dr. Barney, I think your scales have been really helpful. They've been out there, but hasn't hit people's radar, you know, until you need it. So thank you for presenting this again, and thank you for all the work that you did back in August. I shared in the comments the link to Pain Part 1. If you weren't able to join us in August and you want to look at that, you can check out the recording. Again, you're going to get a link to this recording. If you still have plaguing questions and problems, our panelists have gratefully made themselves available to you. You can reach out for me. I can connect you with them, or even Dr. Schwantes and Dr. Barney put their emails out there directly, and Dr. Beisang is absolutely available for you to visit him in clinic at Gillette at the Rett and Related Disorders Clinic. So thank you so very much for your time. You all are incredible. This is one of the most distressing, complex topics we experience in our life. So thanks for being a partner with us. We're very grateful for having us.
Thank you all.
Bye now.
All right, so thank you to all of our panelists. Please continue doing the great work that you're doing. We have a long way to go, but you've helped us so far. And to our attendees, we hope that you also found value in today's session, and that the knowledge you learned today will empower you in ways great and small in the challenges that you have in your life, and that you'll share this information with others in our community as you see these questions come up in the forum, or when you're at different events and with your regional groups, that you'll share this recording, because this is a big issue for our kiddos. And as you go about the daily work and care of your child, we want you to know that you can take hope that rettsyndrome.org will continue to work with such amazing professionals to continue to advance the field and impress upon everybody the urgency with which we want to see change for our kids. Your days may be long, but we are all up to the task when we're empowered with factual guiding information. So thank you for being with us today and learning what you can learn to help your children. And our closing request to all, especially to families, is that you try your best to understand how to advocate for our mostly nonverbal children. Don't give up on them. Remain optimistic and replenished in your own lives, because their success hinges on you. So we want you to be well. Take the information you learned today, apply it, share it with others. This is a team effort and we can have success. So believe in our kids. We'll all be part of something special. We already are part of something very special. We'll see you again on June 15th as we begin to turn into the second half of 2021 RettEd programming. If you would, please take a moment to complete the survey, at the very brief survey at the end of this RettEd. Your comments and feedback really do help us fine-tune future offerings of this kind. If you have questions that come up in your mind after you digest the information from today, again, reach out to us. We're here for you. This is not a one and done topic. Thank you. All right, until we speak again, be well, try hard, get vaccinated, stay healthy, and know that we care deeply. This concludes our webcast today.